Necrotizing Ulcerative Gingivitis. Disease and treatment. Imagine a worried patient who has pain in the gums. It could be gums, painful ulcers, or a combination. That is nothing but necrotizing ulcerative gingivitis. Necrotizing ulcerative gingivitis is a severe inflammatory disease of the gingiva that is painful. It is caused by bacteria and occurs in impaired host with risk factors like poor oral hygiene, smoking, poor nutrition, or compromised immune system. It can involve single tooth or several teeth. Necrotizing ulcerative gingivitis, or simply NUG, has clinical signs of necrosis and sloughing of the gingival tissues. There may be systemic symptoms. NUG is no more called as NUG as there is no chronic form that exists. Oral signs and symptoms of NUG are there are characteristic lesions that appear as punched out crater-like depressions at the crest of the interdental papilla. They may extend to the marginal gingiva, but rarely to the attached gingiva and oral mucosa. These ulcers are covered by a grey pseudomembranous slough, and there is a pronounced linear erythema around the lesion. When there is no slough, the lesion appears red, shiny, and hemorrhagic. NUG destroys the gingiva and the underlying periodontal tissues. NUG can be superimposed on gingivitis or existing periodontitis with periodontal pockets. It does not lead to pocket formation as there is necrosis of the gingival and the junctional epithelium. The lesions are extremely sensitive to touch, and the patient may feel constant radiating and gnawing pain. This can intensify with the consumption of spicy or hot foods and even during chewing. The patient may experience fetid odor, foul metallic taste, or excessive amount of pasty saliva. Extraoral signs and symptoms include local lymphadenopathy and slight elevation of temperature. This is seen in mild to moderate cases. In severe cases, there could be high fever, increased pulse rate, leukocytosis, loss of appetite, and general lassitude or weakness. It can be accompanied by insomnia, constipation, gastrointestinal disorders, headache, and mental depression. In very rare cases, gangrenous stomatitis or noma can be seen. The clinical course of NUG. Severity of NUG can diminish without treatment, leading to a subacute state with milder clinical symptoms. Or it can lead to progressive destruction of periodontium and gingival recession, which can be accompanied by severe systemic complications. When periodontal attachment and bone loss occurs, the condition is called as necrotizing ulcerative periodontitis. Histopathology of NUG. NUG is an acute necrotizing inflammation of the gingival margin, which involves stratified squamous epithelium as well as the connective tissue. The epithelial changes are seen in the surface epithelium, which is destroyed and replaced by a meshwork of fibrin, necrotic epithelial cells, polymorphonuclear lymphocytes or leukocytes, and various types of microorganisms. This appears clinically as the zone of pseudomembrane or surface pseudomembrane. At the immediate border of the necrotic pseudomembrane, the epithelium is edematous and the individual cells exhibit hydropic degeneration. Connective tissue changes are hyperemic with numerous engorged capillaries with dense infiltration of PMNs. This is clinically seen as the linear erythema beneath the surface pseudomembrane. Plasma cells can appear in the periphery of the infiltrate. Bacteria and NUG. The exudate present on the surface of the necrotic lesions contains microorganisms. These can be cocci, fusiform bacilli, spirochetes. The layer between the necrotic and the living tissue can be composed of fusiform bacilli, spirochetes in addition to fibrin and leukocytes. The underlying living tissue may have spirochetes and other bacteria. Diagnosis of NUG. Based on clinical findings such as gingival pain, ulceration, and bleeding, it can be diagnosed as NUG. Microscopic examination is not sufficient as it does not give a specific diagnosis. This is due to the bacterial flora, which is common to marginal gingivitis, periodontal pockets, pericoronitis, or even primary herpetic gingivostomatitis. So, differential diagnosis can be given for NUG, and the most important ones are herpetic gingivostomatitis, streptococcal gingivostomatitis, and agranulocytosis. Necrotizing ulcerative gingivitis versus herpetic gingivostomatitis. Treatment options of these diseases vary dramatically. Misdiagnosis and improper treatment may lead to exacerbation of the condition. Like in case of primary herpetic gingivostomatitis, there is vesicles and diffuse erythema, and early diagnosis can result in treatment with antiviral drug. Such antiviral drugs could be ineffective in NUG, whereas treatment in case of herpetic gingivostomatitis with debridement could exacerbate the condition, and debridement is useful only for NUG patients. NUG versus streptococcal gingivostomatitis. Gingivostomatitis is characterized by diffuse erythema of gingiva and other areas of the mucosa where there is no necrosis of gingival margin and no fetid odor. Bacterial smear shows Streptococcus viridans. Necrotizing ulcerative gingivitis versus agranulocytosis. Agranulocytosis is characterized by marked decrease in the number of circulating PMNs. The lesions are involved in the throat and the mucous membrane regions, and it may include ulceration and necrosis of gingiva that resembles that of NUG, but it lacks the severe inflammatory reaction which is seen in NUG. NUG versus Vincent angina. Vincent angina is a fusospirochetal infection of the oropharynx and throat, and it can extend to the larynx and the middle ear. It can be distinguished from the NUG, and NUG only extends up to the marginal gingiva. A serious systemic condition such as leukemia or acquired immunodeficiency syndrome renders the host immunocompromised, and these can be predisposing factors to cause acute gingival disease like NUG. It is important to rule out the presence of systemic condition in such cases. Etiology of NUG. It involves the role of bacteria, role of the host response, local predisposing factors, and systemic predisposing factors. Coming to the role of bacteria, specific bacteria in the form of fusiform bacilli and spirochete organisms are involved in the causation of NUG. They can be Treponema microdentium, Borrelia species, Fusobacterium species, Cellulomonas species, and Prevotella intermedia. Coming to the role of host response, NUG is associated with physical and emotional stress, which results in decreased resistance to infection. Presence of specific bacteria but no predisposing factors will not be resulting into development of NUG, as this is insufficient to cause the disease. NUG is not found in well-nourished individuals with fully functional immune system. It is only seen in individuals who develop nutritional deficiency, fatigue, habits like alcohol and drug abuse, psychological factors involving stress, and other systemic diseases. Local predisposing factors: pre-existing gingivitis, deep periodontal pockets, pericoronal flaps, injury to the gingiva, and smoking. These are the areas that are favorable for the proliferation of fusiform bacilli and spirochetes. Malocclusion such as palatal surface behind the maxillary incisors, labial surface of the mandibular incisors predispose these areas to development of NUG. Coming to the systemic predisposing factors. Systemic factors can lead to immunodeficiency. These can be seen in conditions like nutritional deficiency, fatigue, habits, psychological factors including stress, and systemic conditions like diabetes. Psychological stress can be seen in case of induction into armed forces, academic examinations, which increase the autonomic nervous activity. Systemic conditions like diabetes, syphilis, cancer, ulcerative colitis, blood dyscrasias like leukemia and AIDS can predispose an individual to development of NUG. Prevalence and epidemiology of NUG. NUG occurs in individuals of all ages. The highest incidence is reported at ages between 15 to 30 years. It is seen in children from low socioeconomic groups in underdeveloped countries. It may also be seen in individuals with Down syndrome. Management of necrotizing ulcerative gingivitis. The criteria involves relief from acute symptoms by reducing the microbial load and removal of necrotic tissue, treatment of chronic disease, either the underlying acute involvement or elsewhere in the cavity. Third is the relief from generalized symptoms like fever and malaise, and finally correction of systemic factors which contribute to the initiation or progression of the gingival changes. So treatment is provided in orderly sequence, which involves the first, second, third visit, and persistent or recurrent cases will be treated as per the need. In the first visit, comprehensive evaluation of the patient is carried out, where medical history is taken regarding the recent illness, dietary background, cigarette smoking, type of employment, hours of rest, risk factors for HIV infection, and psychosocial parameters like stress. Information regarding history of acute disease, that is, onset and duration, recurrent occurrence, foods, exhaustion, mental stress, or any previous treatment. Initial physical examination involves the general appearance, presence of halitosis, skin lesions, vital signs including temperature, palpation of presence of enlarged lymph nodes, especially the submaxillary and submental nodes. The oral cavity is finally examined, where the NUG lesion distribution and oral hygiene is assessed. The goals of initial therapy is to reduce the microbial load and remove the necrotic tissue. This is helpful in repair and regeneration of normal tissue barriers. So the treatment is confined to the acutely involved areas in the first visit. The areas are isolated with cotton rolls and dried. Topical anesthesia is applied, and after 2 to 3 minutes, the areas are gently swabbed with moist cotton pellet. This is to remove the pseudomembrane or non-attached surface debris. Each cotton pellet is used in small area and then discarded. Sweeping motions over large area using the single pellet is not recommended. It is cleansed with warm water, followed by superficial calculus removal. Ultrasonic scalers are very helpful for this purpose because they do not cause pain and help in water jet and cavitation that acts as a lavage for the area. Subgingival scaling and curettage is contraindicated in this case as it can extend the infection into deeper tissues resulting in bacteremia. If there is no emergency, extraction or periodontal surgery are postponed until the patient becomes symptom-free, that is up to 4 weeks. This is to avoid development of acute symptoms. Antibiotics are prescribed in moderate to severe NUG cases and in case of local lymphadenopathy or systemic signs. This involves amoxicillin 500 mg orally every 6 hours for 10 days. In case of allergy, erythromycin 500 mg every 6 hours or metronidazole 500 mg twice daily for 7 days is provided. Systemic complications should subside in 1 to 3 days. Instruction to the patient after first visit involves to avoid tobacco, alcohol and condiments. Rinse with a glassful of equal mixture of hydrogen peroxide and warm water every 2 hours and or 0.12% chlorhexidine solution twice daily. Adequate rest is advised. Brushing is done with just water and an ultra soft brush to remove the surface debris. Chlorhexidine mouth rinses help in controlling the biofilm. Ibuprofen is appropriate for pain relief, and systemic involvement cases will require bed rest and lots of fluid to be consumed. Patients are asked to report back to the clinician in 1 to 2 days from day 1 visit. The second visit involves evaluation for improvements of signs and symptoms. Pain is generally reduced by second visit, and the gingival margins are erythematous but without the superficial pseudomembrane. Scaling can now be performed if necessary. There is shrinkage of gingiva and the previously covered calculus may now be removed. Instruction to the patients remains same after second visit. In the third visit, approximately 5 days after the second visit, the patient is checked for symptoms. Gingiva may be slightly painful on tactile stimulation. Hydrogen peroxide rinses are now discontinued, but chlorhexidine may be continued for 2 to 3 weeks. Scaling and root planing is completed if necessary. Comprehensive treatment plan for patients with periodontal condition is now designed. That involves treatment of gingivitis, periodontal pockets, pericoronal flaps, and elimination of all forms of risk factors. Patient is reevaluated approximately 4 to 6 weeks after treatment. So to summarize, NUG involves clinical signs of necrosis and sloughing of gingival tissues. There are punched out crater-like depressions at the crest of the interdental papilla. It is covered by a pseudomembranous slough, and there is constant radiating and gnawing pain. The etiology of NUG is there is role of bacteria, host response, local predisposing factors, and systemic predisposing factors. Treatment involves first visit to reduce the acute symptoms, second visit involves completion of the scaling, third visit involves completion of the remaining treatment or chronic condition, and further follow-up for persistent or recurrent cases is advised. You can find the link to MCQs on this topic in the description of the video. We hope you liked the video, and if you did, please subscribe to the channel and hit the notification bell for update on new videos. Thank you.